Please come to the front if you can, if you wish. Well, welcome to an ongoing tradition at the CUNY School of Public Health, which brings the students to the fray of competition of creating new knowledge. Otherwise, we call it our Student Science Day. I think this is an opportunity for students across the campuses to get to know each other and meet each other. There are certain things that are also evolving in terms of us encouraging our students to make oral presentations, not just make a poster, as well as supporting and recognizing students that produce other forms of expression of their scientific endeavors, including our new film competition for our public health academic family. There's no question in my mind that this is one of the many endeavors of the CUNY School of Public Health faculty and students to move science forward. And we are in public health so lucky because we are in a domain that moves every day and changes every moment. So that there's always room to create new evidence. A very important aspect of being in the domain of public health is our willingness to learn more, evolve, even change our opinions sometimes based on new knowledge that is being created. And as you know, new knowledge sometimes competes with old knowledge. And I don't know whether you know the history of Pythagoras and Pythagoreans in Greece when they believed in a certain numerical theory, and when their numerical theory was defied, in fact, they captured the defiant and threw him in the sea. So we hope not to do the same thing, but to be open to challenging many of the norms as public health as a science is evolving. And the great thing about public health as a science is that it incorporates knowledge sense, data sense, as well as numerical sense. And there aren't very many fields of practice and knowledge that are so integrated. Walking past the abstracts that have been transformed into posters outside confirms the wide array of topics and approaches, some being quantitative and some being qualitative, in creating that new spectrum of products by the students. My hope is that this is a first step, that the students who have successful posters will also consider participating in national presentations. Last year we had an excellent showing of our students at the American Public Health Association. This year it's in New Orleans. I don't know where it's going to be next year, but the Dean's Office at the School of Public Health supports students who have presentations that have been accepted at APHA as first authorship. It allows you to engage public health professionals from around the country and engage your fellow students in a different environment. I encourage you to participate, and if you don't try, you won't know whether your submission is accepted and whether you are allowed the opportunity to share your experiences with others. Today, the concept was for the students and the faculty to share their experiences, one with the other. We will start with the faculty sharing some of their research experiences and some of their contributions in creating new knowledge in public health. And we as a group of faculty, as a family, thought together and scratched our heads and decided that perhaps a very good representative of our family of faculty today would be none else but our dear colleague and esteemed colleague, Professor Lorna Thorpe. And may I ask Lorna to come to the front of the podium. She's going to give you her experiences as a public health practitioner and academician, and she is one of those that is truly engaged with the quantitative sciences as an epidemiologist and a director of our Epi and Biostat group. She discerns through data collection and analysis, discerns information about populations that helps us predict the future of health within communities, but also think of the weak link in the disease model where an intervention can be most successful. But we as public health academicians and scientists are also people, and so Lorna is a mother and a wife and a very conscientious citizen of our community here in New York City. I'm very pleased to introduce you as a success across the board, which takes a lot of energy. I could quote you how many papers she has published, but truly what makes her a very good role model is that she tries to lead a life with its breadth and its depth in ways that are most meaningful to her, which makes her a successful contributor to public health. Welcome, Lorna.
Thank you. People who know me know I really do enjoy being introduced as a mother. That's something, we all struggle with the balance, and it's really nice sometimes to have that recognized. I'm just looking to see why I cannot move the cursor and bring up my slides. There they are. Let's see. So the focus of my presentation today, I'm going to speak for about 15 minutes, and then I have a panel of students that are working with me. I have an undergraduate student with me, a couple in the audience actually who are working with me. So some master's students who are in the audience, one of whom recently graduated from our program and will speak, and a doctoral student who is working with me who will speak also. And so really, what I'm presenting here is predominantly an introduction, a platform to end up on a dialogue about working together, faculty and students, and hopefully we can have a rich discussion about that. I'm going to talk to you about a study called New York City Hanes. Some of the faculty have heard about this study more than once, so I apologize. But for some of you it may be new. How many people in the audience have heard of NHANES, the National Health and Nutrition Examination Survey? Great. Okay, I'm glad you do. Well, in 2004, we conducted the first local HANES, the local Health and Nutrition Examination Survey here in New York City. And the reason we did so was because, and this is when I was back at the New York City Health Department. I arrived to the Health Department in 2002, and the lay of the land back then was that almost all of the direct federal funding to New York City Health Department was for the conditions shown on the left of this graph, and the funding amounts are shown in vertical green bars. So we're receiving a lot of direct categorical funding to address these conditions. But when you contrast that to what the leading causes of death were, and in particular premature death, you could see that we were receiving almost no federal funding at the New York City Health Department. We had almost no surveillance systems to monitor the leading causes of morbidity and mortality today. And so our first year or two at the health department, my job was to build chronic disease surveillance and epidemiology, and our first couple of years we're building those systems. And some of those systems students now use in their coursework and faculty use in their research. The Community Health Survey, which is a random digit dial telephone survey here in New York City annually, the Youth Risk Behavior Survey, some height and weight surveys, some surveillance on hospital discharges, and on injury surveillance. And that was a lot of work, but it left us with unanswered questions. And some of the main unanswered questions we wanted to address were around the spectrum of chronic diseases and also chronic disease management. For example, we were having a discussion with our then commissioner, and he said, as the city health commissioner, I want to know how many New Yorkers have hypertension. And I want to know how many of them know it, and how many of them are adequately controlled across medical systems, not specific to any one medical system. And that was a very challenging question for us to answer with the very crude systems that we had. And we said, well, you have to build something like a mini HANES. That's That's what the NHANES national study does. And so that, and the following questions here about what's the whole distribution of chronic diseases or cardiovascular risk factors, like what's the whole distribution of glucose metabolism in our population, or of cholesterol in our population? How many people are adequately controlled for these conditions? In order to address that, we built something called New York City HANES, and we worked with the NHANES team. We designed the study to be directly comparable to theirs. We benchmarked our study on their interview. We benchmarked our procedures on their procedures, our physical exam on their physical exam, our lab testings. We used the same labs as they used to avoid any introduction of additional artifact or noise, so that we could say, what's New York City like in comparison to the national average? And that was a lot of work. And in 2004, we spent 6 months in the field. This was unusual for a health department to do, and it was funded by the health department using scrappy dollars taken from across 3 fiscal years. And it was hard work. Our sample size target was 2,000 adults. We randomly selected households. First we randomly selected neighborhoods, then we randomly selected households, and then we went to that house and we tried to persuade them to take part in an interview and a physical exam and give blood and urine. And New Yorkers don't like this. And so, they're busy, they're not home, and they are wary. And so all surveys in the United States have the lowest response rates in the Northeast, and of the Northeast area, New York City has the lowest response rates. And so that was what we were up against. We did a health interview, both a face-to-face interview and what's known as a CASI, where you could ask questions about sensitive topics like sexual behaviors, drug use, jail incarceration history, and that's basically the person does the interview themselves and answers in response to listening to questions, and there's no interviewer seeing what they respond to. We did a physical exam looking at height, weight, waist circumference, blood pressure. We took a series of, we took blood and urine, and we looked at a series of analytes, including your lipid profile, cholesterol profile, glucose metabolism profile, some infectious diseases, hepatitis B, and at that time herpes simplex virus 1 and 2. We looked at environmental biomarkers, very interested in the urban environment, what the impact of the urban environment is on health. So we looked at lead, mercury, and cadmium, and we developed a repository. So really quickly, in a few slides, I want to say, what were the policy influences of the study then? This is a one-time cross-sectional survey, and cross-sectional surveys are, a snapshot in time. They're not very strong study design, but they give us a good sense of burden. What we learned, this is a graph that looks at diabetes, but what you see in dark blue is the prevalence of diabetes as the participant was reporting. Yes, I've been diagnosed with diabetes by my provider across different demographic groups. In pale blue, what we're showing here was the prevalence of undiagnosed diabetes. So in other words, their fasting glucose metabolism level, according to our blood test, was consistent with the diagnosis of diabetes, but they reported that they had not been diagnosed with diabetes, and that's how the national study looks at undiagnosed diabetes. And we found variation across a number of different demographic subgroups. Overall, in pale blue, 12.5% of New York City adult residents have a diagnosis, or have diabetes, 1/3 of which is undiagnosed. But in addition to that, in dark blue, we found that nearly a quarter of adult residents had a fasting plasma glucose level that was elevated above normal, consistent with what we call prediabetes or impaired fasting glucose. So nearly 1/3 of New York City adults are walking around with abnormal glucose metabolism levels. And it was really some of these findings that strengthened our resolve at the health department that we needed to be working at population level, not just patient level, in terms of improving the physical environment, working with the food environment, trying to improve the health of New York City residents through policy, not just through individual patient programs. It also supported the development of now what's a well-known innovative strategy that occurred here in New York City, and that was making A1C tests, which is essentially a laboratory test to assess your control of your glucose levels. Those laboratory tests became, by policy, reportable to the health department. So all labs that perform that test have to report the results to the New York City Health Department. And there's probably many people in the audience who actually work at the health department. And so that A1C registry was really a page from the book of what we do with communicable diseases. And it was saying, if we want to get above and sort of get a handle on this diabetes epidemic, and also on management of diabetes, we need to track it. And this is one way to track it that doesn't put a burden on the patient. And it was the findings from the New York City Haynes study that really allowed the regulation to pass. It really provided us with a lot of evidence that not only did we have a lot of diabetes, but we also had poor control, because the study looked at control of diabetes. In terms of smoking and cotinine levels, so in 2004, this is a snapshot of a graph that's well known and many people have seen it, but it basically is a graph of smoking in New York City. And smoking was at sort of a steady state for many years, at around 20% or 21% of adults smoking. And then with a series of aggressive, innovative policies, smoking prevalence started to decline a little bit, right, from early 2000 to 2004. We came in and did the survey, New York City Haynes, and we looked at people who reported not being a smoker. And we said, among non-smoking New York City adults, how much exposure to environmental tobacco smoke have they had? We can look at a biomarker called cotinine. And if it's elevated, that shows they've been exposed. And if it's not elevated, they haven't. We anticipated, because our smoking rates were lower than the national average, that we would have lower than the national average of people who had elevations in that cotinine measure. And this is a review of how we measure cotinine. If you have under 10 nanograms per milliliter, that suggests you're a non-smoker. But if you have above a certain cutoff, above 0.05 nanograms per milliliter, that means you've had some exposure, elevated exposure, to tobacco smoke in your environment. Maybe somebody smokes in your home or in your workplace. And what we found was a surprise. We found that New York City adults, on average, a higher proportion of New York City adults had elevated cotinine levels compared to the national average, despite the fact that our prevalence of smoking was lower. And this was really surprising to us at first. And then as we looked into some of the data from the national study, and we analyzed rural versus urban in the national study, we saw this to be an urban phenomenon because, of course, we live in a densely populated environment. We come into contact with environmental tobacco smoke more, maybe in our apartments. We live in a lot of multi-unit housing, and many studies have shown that smoke permeates apartment buildings, and even children in families of non-smokers have higher levels of cotinine if they live in multi-unit housing compared to children of non-smoking adults in detached housing. So this multi-unit housing is a real issue for us, but also we come into contact with smoking on our sidewalks or going in and out of large apartment buildings and office buildings when people are crowded around the front doors. So that finding really was an important piece of our advocacy puzzle when we were trying to advance policies to restrict smoking in New York City, including restricting smoking in parks and beaches, as many of you know occurred just a couple of years ago. Two other findings really quickly. We identified elevated levels of blood mercury in our foreign-born adults, particularly in our foreign-born Asian and Chinese specifically, had the highest rates of blood mercury, and that was directly correlated with fish consumption. We know eating fish is good for you, but eating too much fish can have some consequences health-wise, such as elevated mercury levels. And some fish are worse than others. So we used those findings to actually do a survey of fish in fish markets, particularly in Chinatown areas, and to put out targeted information to the Chinese and Asian communities about which types of fish have elevated mercury levels and how to eat fish wisely. And I still use this with my children on choosing which fish to eat. One other mercury finding that was really interesting, we had one person with very high levels, emergency levels of urine mercury in our survey. We sent an environmental team out to interview her and try to figure out why her urine levels were so high. Turns out she was using a skin lightening cream. That's shown here, that skin lightening cream, actually has elemental mercury as one of the ingredients, and it was being sold in bodegas in the Dominican community. And we issued a commissioner order to seize sales of that product, and it's no longer available in New York City as a result of that one person in the survey. So that was just from a one-time cross-sectional survey. We're doing it again now. We've been in the field since August of 2003. And there are two main ideas for why we're doing this survey. One is to look at and try to use these 2 time points, 2004 and 2013, and look at how has population health changed over time using things like biomarkers, and identify whether or not some of the innovative policies that have been introduced in New York City in the interim have had an impact on our health that we can document. And we use the national study as our comparison group. So we're going to see declines and changes in some of these health conditions, but have our declines and changes been different than the average trend overall nationally or in urban settings? So these are just some examples of policies that have occurred over time. We will look at things like, because we have a repository from 2004, we'll look at trans fatty acid biomarkers in 2004 and in 2013-14 to see whether or not taking trans fatty acids out of restaurants has had a positive impact on the health of New Yorkers, and that we can at least put some contributory evidence towards that. This is not a perfect study design, but it's adding to the arsenal. Evaluating policies is not always a very easy thing to do from a study design perspective, but this adds to our arsenal of knowledge about what's working and what's not. So that's one of our main foci of this study, is to evaluate city policies that have occurred in the last decade. We're also very keen to continue the surveillance and monitoring of major chronic conditions. So how are we, agnostic of healthcare institution, doing at managing diabetes, managing cholesterol, managing hypertension, and how are we doing it by certain subgroups? And that's particularly interesting with the rollout of healthcare reform. This is a partnership, a very strong, very committed partnership between the CUNY School of Public Health and the New York City Health Department. This study is being led by CUNY, but I have to say a tremendous amount of the work is being done by the health department. A lot of in-kind support for this study is occurring. The public health laboratories are amassing all of the biospecimens. They are accessioning them and storing them and shipping them to the laboratories. That takes a lot of work. There are staff that are collecting the results from the laboratories and providing those results back to survey participants, because one of the things we do is we give results back to participants as well as giving them $100 to take part in the survey. And so we're doing what we did last time in 2004. This is a random sample of households, 3-stage cluster sample, to be specific. And we are doing a physical exam, a health interview, and taking blood, urine, and now we're also taking saliva. A couple of things that are new about the study this time. In 2004, when we selected your house, we had to persuade you to take part in the survey, which was very hard, but then we had to persuade you to come to a clinic to take part in the survey. This time we're doing everything in the home. And so we had to figure out how to take all this blood and all this urine, all this saliva, do the physical exam, height, weight, and everything in the home. And we literally had to figure out how do we centrifuge this tube in 30 minutes, centrifuge this tube in 45 minutes after letting it sit for a little while, store this one on ice, store this one on, keep it warm, and get it all over the city within a certain amount of time. Very difficult. And there are a lot of people in this audience who are working incredibly hard to make that happen. We are doing some new tests. We're looking at hepatitis B, hepatitis E. We're collecting oral saliva to look at oral HPV, and we have a real interest in writing some grants to look at the oral microbiome, and that work is being led by other faculty here, Heidi Jones, Jen Dowd, and Levi Waldron. And we have a larger repository this time. We have more sera, the biorepository. Some of it is very dedicated to CUNY-specific led research. Some of it is dedicated to the health department-specific research, and then a whole bunch of tubes are in the middle we're going to share. And we have a very detailed memorandum of understanding how to share that. We have a lot of new questions on our questionnaire, an expanded section on sexual behavior, an expanded section on drug use, and a whole section on how you visit with your primary care provider, and we consent people to look at their medical chart reviews, because there's a whole other aim to this study that I'm not talking about here, which is to validate electronic health records as a population health surveillance tool. So we don't want to have to do this every 10 years. This is too hard. So how are we doing? As several people in the audience know, including our dean, who's been a great supporter since he arrived, it's been hard. It's been uphill the whole way. It's been harder this time around than in 2004. And all survey research says that. People are over-marketeered, over-solicited, definitely less trusting of government than they were in 2004. So we've completed 1,400 interviews to date. We actually may be at like 1,398, but we're 1,400 essentially. The field conditions are very, very challenging, and that's what I'd love for the students to talk about. New Yorkers are just not at home, and when they are at home, they're more likely to refuse due to issues of confidentiality or just not having time. Everybody's overworked, everybody's over-informed about options. And so we've extended field data collection a couple of times, and now we have a hard stop on June 19th, and we are gunning really hard to get as high a response rate as possible in the next 5.5 weeks. There's a tremendous amount of people involved. I've just highlighted in bold where we have students involved, and we have students or ex-students everywhere. And we have just a great number of funding sources. The primary funding source is the Beaumont Foundation, but there are 4 other foundations involved listed here. We've had great support from CUNY, from the Dean's Office, from the Chancellor's Office, from Hunter College. The New York City Health Department has contributed direct funds to support the extension. This is one graph, one photo of myself and Amy Freeman, who's a current master's student, and the full-time survey coordinator, who has been a rock. And she's not here today, but she's been a rock on this study. But with 8 of 11 CUNY Service Corps members, and I don't know if you know about the CUNY Service Corps, but it's out of the Chancellor's Office, and one of the students will speak today. They're fantastic, undergrads mostly, from all across CUNY, who have been really great to work with and a huge source of inspiration for us, ready to go out into the field when it's 6, 8, 10 degrees, knocking on doors and being yelled at. And this is a mixture of CUNY and Health Department team members. I don't have a photograph of everyone. This is our website if you want to learn more about the study. So I do have 3 students, and I don't know exactly how we wanted to do this, but why don't the students come up, Meg, and Mark, and Jessica. And I just want the few other people that are involved in the study. Jane is here. Kriti, are you here yet? No, she's probably not here yet. A few more are in the audience. Just want to acknowledge them. And I think the format we were asked is that each is going to talk for a couple minutes about their experience on the project as a student and what they're learning about from it, and then take questions. Why don't we start? We're going to go from undergraduate to doctorate. And start with Meg Baker, who is an undergraduate student at Lehman College and interested in GIS and health administration. I think you may not need to shout.
Okay, so mine is going to be a little bit more personal because because while the Service Corps members, we basically fill in wherever we're needed, whether that's going to households and screening, or right now I'm working on some centralized scheduling, which is scheduling the people who've already been screened to either come in or have someone come to their home to do the interviews. So I'm just going to give you a little bit of background on me, where I come from, and why something like Haynes is so important to me and to other Service Corps students. So I was a theater major at SUNY Purchase. It's a big change. In 2008, when the recession hit, both my parents were small business owners, and I had to drop out of school. I was 20. I was on my own, and I'm from Maine originally, so I had to make it into the city on my own. Fast forward 3 years, several minimum wage jobs, theater projects, you name it. I knew I needed to go back to school, but I was not keen on going back to the theater world. In that time, I also realized that the news that I was choosing to read on my own was health related. Talking about the statistics, what the problems were, the policies. So I've head to Lehman, and I remember there was actually one podcast that really kind of captured my interest. And it was, I think, like a This American Life or something, talking about the search for the cause of AIDS and kind of really trying to get down to the moment where it crossed the species line and became a human problem. And that was like a huge ta-da moment for me. I was like, people can do that to work? And I just really remember that as being a huge, and I've never been so fascinated by anything before. I was also, there's a lot of stuff going on that's still going on right now with the debate on the policies surrounding funding for low-income people in Medicaid, Medicare, and what rights they have to life benefits. That was, I was one of those people. I was 20. I wasn't making very much money. In fact, in 2011, when I was 22, I was uninsured, underpaid, and then I was diagnosed with multiple sclerosis. A disease that left me leaving the hospital with very little answers, a $50,000 hospital bill, and some serious fire to figure things out at a larger level. Actually, that same week I was accepted to Lehman College for Health Services Administration and Geographic Information Science. I've since extended that into psychology as well and hope to kind of use all three programs to go into epidemiology. It's been rough. I'm now 25 and just starting to finish my bachelor's degree and trying to take a slow route without burning my candle at both ends. But when I was accepted to the Service Corps, I remember going through all the lists of all the partner affiliations. I spent lots of time researching Lorna, and Haynes was the only one that I wanted. It was the only match that would give me the experience that I wanted to get my PhD in epidemiology. I didn't get it, though. That was a problem. So thankfully, I felt bold enough to email Lorna, email several different people, and change that. And I was then placed into this placement, which has been life-changing. Working here and with Lorna and Amy has validated my professional journey and piqued my interest more than any job that I've ever had. The professionalism I've experienced here from everyone involved, and the team mentality and motivation I've seen from other Service Corps members has just blown me away. Even throughout the several changes that we've experienced has been valuable, despite what Lorna and Amy may think, and I know what they worry about. But as I learned from my many years with theater, so much can be gained from when things feel chaotic. Some of the most valuable things I've learned have just been watching Lorna and Amy manage those changes and manage the flow of different people in different systems with a grace and concern that I know can only come from the very best. And you learn so much about yourself too, as a person and as a student, when you're on your own and you must make human decisions while keeping the project's goals, Haynes' goals in mind. When I was thinking about presenting today, I sent out an email to the rest of the Service Corps members just asking for any stories, any maybe unexpected experiences they had while in the field. And, as Lorna mentioned, New Yorkers are not keen on their privacy being invaded, so I was really expecting some very colorful situations. But I was very surprised with the response I got, and I had to give it some thought. For the stories that I received showed a strength and just kindness from the Service Corps students that just once again made me so happy to be here. Jane, who's sitting right over there, emailed me and was just talking about how, and I'll just quote her, "My partner and I went to screen a home we visited several times but could not establish contact with. We finally spoke to an elderly neighbor who told us that the family we were looking for had moved. but she herself was having trouble finding a new apartment due to the high rent rates. We later came back and gave her an address of a building that houses elderly residents. This story struck me for several reasons, but mostly because I'm not sure that I would have thought to go back and do that. And though her gesture was not a part of the Haynes Project's goals, and it wasn't specifically something that we were supposed to do or part of our job criteria, I really feel like that action is representative of why we're all here and why the service corps members got involved. I think it can be difficult to keep that in mind when we're juggling so many things, but Jane's action was a reminder of that humanity, and all of our service corps members are like that. So I really just wanted to take right now to thank Lorna and everyone in this room who was involved with getting the students on board. I think for most of us, it has only strengthened our excitement about this field. Thank you.
I'm going to try it without the microphone. See how I do. I am a former epidemiology graduate program.
It's better if you use the mic.
Use the mic? Yeah, use the mic. All right. I actually had class here. I was an epidemiology master's student. I actually was in class with some of the people that are here. I'm glad to see you all. I guess my journey on this project has really been one from theory to practice. Because I guess the course of my education, I probably worked on, I would say, 4 of the major studies that are shown at the New York City Haynes. One was New York City Haynes, the 2004 study. I did research on that just as part of my courseload. I also did research on the New York City Community Health Survey, the CHS, and the NHANES and the BRFSS. So for me, these studies have always been sort of publicly available data, and they never really had a human element to them. They were always just data for me to analyze. But working on this project, I would say this is something that's really humanized everything for me. Not only, I think for the people that work on these projects, I have a new respect for anybody who works on any of these studies, because the amount of work that it takes to get people to organize the study itself and then to get people to participate in it is an incredible amount of work. And I would just say that my job, I was brought in to sort of help coordinate the field staff. And it's been difficult, but I would say that the foundation that the service corps students laid was probably the best thing that ever happened to the study, because they probably really humanized it more than anything could coming into it. They really put a face on every single person that we interact with, and I think that's probably the most important thing we do, because this is a voluntary study at the end of the day, and for us to go out and ask these people to participate in the study, it's most important for us to just respect their decision. And the work that they did has been fantastic, and we tried to emulate that with the professionals that we brought on to do the study, and we really couldn't have done it without the students. So I'd also have to say, and I would agree with what Lorna and what Megan said before, the biggest problems that we've encountered in doing this study is that it's really hard in New York City, and I'm sure it's in urban areas as well, other urban areas as well, but it's really difficult to find people at home. And I would say going forward, if anybody's ever going to do a study in New York City, if you can avoid it, try not to do it in the winter time. The results are hard to come by, and your staff and the people that you meet are really going to appreciate when you don't come in the snow. And I know that I got texts, I know that Meg and other students were out in 6-degree weather and feet piled up of snow, drifts, out there every day trying to see if they could find people at home. And that's amazing. I would also say that another large problem that we had, and this is probably typical, I'm sure, for urban areas as well, is that we've had a lot of trouble with gatekeepers for buildings. If you're doing other studies like this, know that when you're in Manhattan, you're going to have doormen building, and it's going to be very, very difficult to get into these buildings. So that it's really important to find people on your team that have an instant connection with the doorman and these other people, so that they can be your go-to people when you need to get into these buildings. Because if you can't work with the gatekeepers, then you're never going to find the people in these buildings. And it's just been our case in the study that we've had a lot of difficulty, and we've identified the people that seem to have magic at the doors. And sometimes it's different for a lot of the buildings. Sometimes Department of Health employees have gained access where no one else has, and sometimes it's just listening and just being really respectful to the doorman and the job that they have to do as well. Other things that I agree with what's been said before is that a lot of the participants have trouble these days with believing what we're doing, seeing that we're understanding that we're legitimate. The legitimacy of your study is hard to convey, and it's an important thing to convey, though. And any way that you can try to get that through to study participants, that what you're doing is not a scam, first of all, and that you can trust you. The trust issue is really the biggest thing. And if you can overcome that trust issue, I've seen a lot of people that they've refused to study flat out, and that on a second chance with a different person who had a different approach, that listened, took the time to listen, and just really had an ear up to their concerns. We've had some breakthroughs, and people have been participated in the study. The staff that you get that you bring to the study, of course, is going to be important in getting that trust. So I would say if you have, if your studies are large, and if you have the budget to earmark for it, spend as much as you can on getting the quality staff that you can bring in, or the best volunteers that you can, that can bring that level of professionalism to the study, and you'll have a lot of success.
Thank you. So, Jessica, I'm the data manager for the NYC Haynes, and a little bit of my history. So, I came here from Colombia, the country, where I study statistics and where I developed my passion for data analysis. But then when I was finishing my degree there, I wanted to use this passion for helping humans. And then when I came to New York, I had the opportunity to work for the Department of Health, and then later on being part of the NIH program, thanks to Professor Hariushi and Lorna. And then I discovered that this passion and data analysis can be very, very useful for helping bettering the lives of humans. And as Mark said, usually when you're an epidemiologist or a data analyst, you just use data. You just get the data and you don't see the human and what is behind the data. What was the effort made to be able to have that data available for everyone else to use. So then when I had the opportunity to join the team as a data manager, I thought a lot because I was just starting the DPH program, and it was a lot of work. I'm still doing it full time and taking all the challenges that entails being part of this project. So I thought about that, but I said that this is what I really like to do. This is my passion. My passion is dealing with data. And also getting to know what is behind the data, how we collected the data. And so I entered into the study as a team member. when Lorna asked me to be here, I asked her, so what kind of things do you think I should be telling people? And she said, talk about your skills. And then, what kind of skills did I bring into this job? So I said, okay, clearly my data analytics skills, but most importantly, customer service. Because, yes, that's something that is not listed in any list of duties for a data analyst, because usually you just deal with data without interacting with the people who collect the data. But then when you're in a data management position, then you really need to deal with the field workers. You need to deal with the participants too sometimes. And you need to deal with the people who will be using your data. So you really, really need to have that sense of customer service to be able to communicate across all of them and give them what they need to make the most out of what we are doing, the data we are collecting. So I think this is a very, very great experience, and it's something that I encourage people to think about, that we as epidemiologists, we also need to have that sense of customer service and think that data there is always something behind that can help us to complete the full story that we are getting when we run those models and get that tables out of for publishing. So that's what I have to say.
Is there time for one or two questions for the student? Any questions, comments?
Do you feel like your skills complemented each other? You're at different stages in your academic career, a recent alum from a master's, an undergraduate student, and a doctoral student. How do you interact? Do you feel like you're helping each other in a certain way, or bringing different perspectives?
I would have to say that, Jessica's got the data management skills that I could dream of. Whiz with Excel and other software. I mean, and she's sort of our go-to person with any problems that we have with helping us try to organize things in our mind. If we have a problem that we need to dream up with how we're going to sort of maybe even follow the data, she can just give us an easy like model for us to actually do it.
Yeah, I think that it's that really that's why we are the great team we are, because we complement each other very, very well. Like getting the students and all the field workers with all their interests and all their skills and their stories about how they get into the campus, how they are able, and then trying to combine data and think about how can we manage that so that we can have can communicate that across all field staff and maybe be useful for everyone, and then how to keep track of every single thing we do, ensuring that the best quality of the data we are collecting.
And the field staff, they can think that the students did. I mean, I don't think I could ever do what they did. I mean, I just don't have the confidence in myself, I think, that they do to go out and try to talk to New Yorkers they've never met and convince them of the study. I just don't think I would fail at the door, but they're successful. So I'm really appreciative of that.
Well, we have a treat to follow this, and we don't want to encroach on the timing for the next treat. And I think we're starting a new tradition. There's going to be a movie showing. So if you don't mind, we can all move after thanking our panel. The next session, which is going to be next door.
Welcome, everybody. This is an amazing afternoon. You've all had an awesome experience, and it's just going to continue. My name is Mimi Fox. I'm a professor here at Harvard in policy management, and interim research director.
And it's been my pleasure to work with Linda McDowell, Professor McDowell, and all the faculty who have been involved with these students. And in particular, I want to give an enormous thanks, and I think a round of applause is deserved to Linda McDowell. Winners. Everybody likes winners. We have winners. The students' research masters or capstone for achievements. These have been, I know as a faculty, it's been very hard to judge between them and among them because there are so many, so interesting, so well presented, so important, so significant, having public health impact, being rigorous. And just being very interesting to read. So we're very proud of all of you. But we do have 4 winners, so it's my pleasure to announce the winners and to have them come up. First, let me introduce Erin Page.
She's doing a badge.
Oh, she's never mind. We're going to keep going.
She'll be right.
Kriti Thapa. Did I say it worded right? Good. Well, and Kriti has written on done research on the impact of caregiver depression on delinquency among child welfare involved adolescents. I want to present you. Please come up. You receive the award, and then you're going to give your presentation, but you're not going to give your presentation right now. But this is a certificate of excellence, and it also comes with a check. Our next winner is Joanna Di Costanzo. Congratulations. Her research is on factors related to social network formation among individuals with severe mental illness. So congratulations. Thank you. Oh, and thank you, Linda. And I also want to present both of you. Here's a photo op. With a Faculty Research Award medal. Our next winner is Lisa Graham. Who did her research on the influence of neighborhood characteristics on childhood obesity, results from the 2007 National Survey of Children's Health. Congratulations. This certificate with a check. Congratulations. And please turn to a second. Mess up this gorgeous hair. There. Patients at the Institute for Family Health, a descriptive profile and process evaluation. So congratulations. Your certificate with your check and your medal of honor. And now I'm going to turn things over to Professor Emma Sui, who is going to moderate for the presentations.
Welcome, everyone. It's really a pleasure to get to moderate this panel of our first ever podium presenters at the CUNY School of Public Health Research Symposium. Our first presenter for the afternoon is going to be Lisa Graham, who is from Lehman College's MPH program in community-based public health and health equity. And as Professor Claus mentioned a moment ago, the title of her talk is "The Influence of Neighborhood Characteristics on Childhood Obesity Results from the 2007 National Survey of Children's Health."
Good evening, everyone. So my presentation will be on the influence of neighborhood characteristics on child obesity, results from the 2007 National Survey of Children's Health. Obesity is a major public health issue in the United States. Between the years 1980 and 2010, obesity has increased for children aged 6 to 11 years old from 7% to nearly 18%, and for adolescents aged 12 to 19 years old from 5% to 18%. Previous literature has outlined that children are spending more time indoors and less time outdoors due to factors associated with the neighborhood physical and social environment. To be more specific, children who live in disadvantaged neighborhoods are less likely to be physically active due to factors concerning safety problems. In addition, children who live in neighborhoods that have low levels of social support are less likely to play outside. There are limited studies that have addressed the association between neighborhood safety and neighborhood support. And so the objective of this study is really to determine whether neighborhood safety and support are associated with obesity and whether these associations varies with age, sex, race, and ethnicity for those children and adolescents who participated in the National Survey of Children's Health. So the data that was used came from the National Survey of Children's Health, and the sample comprised of 42,535. The dependent variable was BMI, and it was categorized according to the CDC age-sex adjusted growth chart as underweight or below the 50th percentile, health weight or between the 5th and 84th percentile, overweight or between the 85th and 94th percentile, and obesity at or above the 95th percentile. I had two independent variables, neighborhood safety and neighborhood support. Neighborhood safety was derived from the question, how often do you feel your child is safe in the neighborhood? With responses, never, sometimes, and always. Neighborhood support was derived from the question, would you say that your child, would you say people help each other out in the community? Would you say people trust each other, count on each other, people watch each other's children, and so on and so forth? The response is yes or no. Multinomial regression was used to estimate the effects of the odds ratio for neighborhood safety and support on BMI categories for the children and for children and adolescents before and after adjusting for the selected variables. Also, we use interaction for the exposure of age, sex, race, and ethnicity that we tested. Also, data management was conducted using SASM at 9.3, and Sudan was used to do the statistical analysis. So this chart is showing the prevalence of obesity for reports of neighborhood safety and support among U.S. children and adolescents ages 10 to 17 years. So as you can see on the chart, I'm not sure if you've seen it clearly, but for children and adolescents who were obese, they were more likely to live in a never safe neighborhood compared to those living in sometimes and always safe neighborhood. Also, for children living in non-supportive neighborhood, were more likely to be obese compared to those who live in a supportive neighborhood.
So never, sometimes, always. The question was
Would you say safety?
yeah.
How often do you feel a child is safe in the neighborhood?
Never is the worst.
Yes. So this is the crude and adjusted odds ratio, 95 confidence interval for neighborhood safety and support. So in addition to the crude, 3 sets of analysis were done. Model 1 is showing adjusted odds ratio for age, sex, race, and ethnicity. Model 2 is showing additional adjustment for physical activity and asthma. And model 3 is showing adjustment for poverty. So as you can see that for neighborhood safety, the reference was always safe. So as you can see, for underweight and overweight, there was not really any significance for crude and the adjusted odds ratio. But when you go further down to obese, the crude was significant, and when it was adjusted for age, race, and sex, age, race, and ethnicity and sex, the significance remained. And for model 2, when it was further adjusted for physical activity and poverty, the significance still remained. And by model 3, by poverty, the significance still remained. So we can conclude that children and adolescents who were obese were 1.9 times more likely to live in a never safe neighborhood compared to those who live in sometimes and always safe neighborhoods.
After adjusting for?
After adjusting for age, sex, race and ethnicity, physical activity, poverty, and asthma. Okay, so for supportive neighborhood, you can see there for overweight, it was not that much significant. It was not significant for the crude and adjusted odds ratio. But for overweight and obese, they both were significant for the crude and adjusted odds ratio. So the conclusion here is that children and adolescents who were overweight and obese were more likely to live in a non-supportive neighborhood compared to those who live in a supportive neighborhood after controlling for the connected areas. So the conclusion, this study found that neighborhood safety and support are associated with overweight and obesity in U.S. children and adolescents after controlling for age, sex, race and ethnicity, poverty, physical activity, and asthma. So the strength of this study, one of the strengths is this was a large and representative sample of U.S. children and adolescents. It also allows to control for potential confounders and interaction. The limitations are NSCH is a cross-sectional study, and because of that, inferences about causal association cannot be determined. Also, the information for this data was self-reported, and so it is recalled to recall bias. recommendations are, first, is to identify the physical and social factors that are contributing to obesity and design programs to specifically address those factors. Secondly, is to improve the social and physical infrastructure within these neighborhoods so that we can create opportunities for children and adolescents to have a healthier and more active lifestyle. Public health implications. Public health should aim at reducing obesity and or overweight through interventions that will take into account the neighborhood context in which children and adolescents live. Also, one of the implications is that developing programs, we should aim to develop programs at changing perception of neighborhood safety and support in neighborhood, which will help children, which will help to reduce or prevent childhood obesity for children and adolescents. My acknowledgement. Without the help of these people, I don't know, this study would not be completed. And so I want to express my sincere gratitude to the CUNY School of Public Health and all the professors in the program. I am heartily thankful to Dr. Louisa Orell for the guidance, encouragement, and support, and also for providing me the opportunity to do this research. I also want to thank Dr. Sui, Dr. Wayne, and Dr. Levitt for their support. I also owe my deepest gratitude to my colleagues and family for their inspiration and prayers. Thank you.
We have a few minutes for questions, if anybody has questions for Lisa about the project.
I just needed to understand your definition of neighborhood geographically and in the context of the size of the population.
Neighborhood safety was derived from the question, how often do you feel your child is safe in the neighborhood? And they were given responses, never, sometimes, and always. The total sample within this data was 91,642, but because we had to, missing data and stuff like that, we came down to a sample of 42,535.
And how many neighborhoods will that population live in? How many neighborhoods?
The data was a representative sample of 50 states and District of Columbia. So,
but how are the neighborhoods defined?
Perceived. They're perceived.
It's just a perception.
Perceived, yeah, perception of persons.
No, not the safety, but the neighborhoods. How are the neighborhoods geographically defined?
They're not, their own definition, my neighborhood. Whatever.
Yeah, that's what I was trying to understand.
How was your physical activity variable defined?
How often do your child, how often do your child,
I'm sorry,
it's all right. How often do your child participate in physical activity during the week? It's like 1 to 3 times and stuff like that. I don't remember the options. But they were given option 1 to 3 times a week, 2 times a week, and stuff like that.
It's just that also within physical activity, it's also within like intensity. Are they sprinting? Or they're just walking leisurely? Like how much? I mean, there's also that factor as well.
Well, they were just given the options to choose, like how often do you feel your child is safe and does exercise during the week. They didn't tell you the intensity of it. They want the number, like how often do your child do exercise during the week, per week.
I'm not here to certainly present any verbiage, it's just that saying that maybe that's a little bit of a limitation, something that we should all think about when we further study this. It's a big public health problem, and that also needs that's for sure.
Yes, that's right. sex, age, and race.
And what did you find? Did you find interaction?
No, regardless, the association remains regardless of age, sex.
All right, so we will wrap up. Thank you very much. Okay. Our next presenter is Erin Page, who is in the Community Health Program at Hunter. And the title of her talk is Retrospective Clinical Chart Reviews of Suicidal Patients at the Institute for Family Health, a Descriptive Profile and Process Evaluation.
Good evening, everyone. My name is Erin, and the title of my paper is Retrospective Clinical Chart Reviews of Suicidal Patients at the Institute for Family Health. So first, I just wanted to give everyone an overview of what I'll be talking about today. First, I'll review suicide statistics, risk factors, and health-seeking behavior. Then I'll talk about the purpose of my research, specifically located at the Institute for Family Health, and their protocols that they have dealing with suicidal patients or high-risk patients. Then I'll talk about the methods in terms of my research and conclusions of moving forward. So who commits suicide and why? The last year that the Center for Disease Control and Prevention had any data on suicide was in 2010, and 38,364 reported suicides that year, with a rate of 12.4 per 100,000. And I just wanted to make note that the rates for suicide attempts are vastly unreported and based on hospital data. And the Substance Abuse and Mental Health Services Association have estimated that there's one suicide for every 25 attempts. So if you do the math, that's 959,000 suicide attempts each year. Suicide rates are highest among older Americans, older white Americans. Men complete suicide 4 times more than women do, and adolescents have one of the highest suicide attempt rates. The causes are complex and multifactorial. Their origins are in structural, behavioral, and genetic factors. Some of these are history of physical violence, history of sexual violence, lack of social support, and amongst other things. So the Institute for Family Health is a federally qualified community health center network. We have 28 centers throughout Manhattan, the Bronx, and the Mid-Hudson Valley region. We serve a large portion of underserved low-income patients that are largely on Medicaid recipients. We have electronic medical records-based protocol for documenting and responding to patients who present with suicide ideation, risk, or intent. And the ultimate goal here is to coordinate care among providers and to set up these protocols and policies so that all providers are aware of the risk, they can rescreen the risk and take the appropriate measures when they see a patient at every encounter. And the reason why my research was very interesting and important to the Institute is based on the health-seeking behavior of people who complete suicide. So 45% of people that complete suicide visit a primary care doctor in the month before they complete the act, and 19% visit a mental health clinician. So my the ultimate purpose of my research was to, one, measure compliance with the Institute for Family Health Suicide Risk Protocol, and to identify the demographic, medical, and mental health indicators of suicide risk in the Institute for Family Health population. So what is our protocol? What do we do when a patient presents with suicide ideation? So the first part is we put an FY on the chart, and I will also show you guys screenshots of what these look like. And this is an alert to alert all providers, whether they're case managers, physicians, social workers, of a patient's risk. The second one is to report suicide ideation or risk on a patient's problem list, or a place where all medical and mental health diagnoses are located. And the third and the last one is to create, review, and have the patient sign a safety plan. So this is an artificial patient. This is an example of an FYI located in the patient chart. This is the first thing you see when you open a chart. And you can see I've highlighted access for suicide ideation at each visit. So no matter what service or what department you are supposed to ask the patients how they're feeling. the second one is recording the suicide ideation or risk on the problem list. I have an arrow there for suicide ideation, and that automatically flags the chart red. And you can see along the top banner that is red, and all staff are trained and know that the red banner means that they are a high-risk patient. And lastly, that's the location of the safety plan. You can see this is my personal safety plan, and of course that's signed by the patient. So my specific methods, I had a variety of sources where I identified my high-risk patients. A lot of them were for incident review committee meeting minutes, where providers come together and report on incidences of suicide attempts, suicide completions, or other type of incidents that happen at one of our clinics. And then I conducted a retroactive clinical chart review, and I identified 83 high-risk patients. So I answered yes or no if they had these three protocols, if they had the FYI, if they had suicide risk or ideation on their problem list, and if they had documentation of a safety plan. And then I compared these protocols to see if the patient had any identification of suicide risk. So this was I found in the psychosocial assessments. So this is an assessment given to all patients that seek mental health services. And this was based on a patient's answer yes to having a previous attempt, and that was my suicide indication. And then lastly, I developed a descriptive profile of the high-risk patients based on their medical, mental health diagnoses. So I created a flow chart here. I'll walk us through it. So I started with N equals 83 high-risk patients, and 4 didn't have psychosocial assessments. So that just meant that 4 patients were strictly seeking medical services. They weren't seeking mental health services. So they didn't have a psychosocial assessment. Along the top in purple are those with a psychosocial assessment and answering yes to having a previous suicide attempt. So in this case, these patients should have all the protocols designated in their chart. And I have circled here if they were partially compliant, whether they had 1 or 2 indicators, and not compliant at all, they didn't have any indicators. So we focused on this portion of the chart, this portion of the model, just to see that these protocols should have been in place, especially for patients that indicated to a clinician that they did have a suicide attempt, a past suicide attempt. And down here, I say that 33 patients, or 61%, of the high-risk patients who had a past attempt did not have all 3 indicators. So either had 1 or 2 indicators located in their chart. This was for the descriptive profile. I just wanted to highlight the top 5 psychosocial risk factors. Financial difficulties. This is if they're having trouble paying for rent, for food, they were on Medicaid, or the recipients of food stamps. Family dysfunction, family history of mental illness, history of substance abuse, and history of sexual abuse. And this chart, mental health diagnoses and medical diagnoses, this was to be as expected in the literature. The literature has a plethora of knowledge on the associations between medical diagnoses and mental health diagnoses and suicide. But I wanted to bring our attention to the highlighted area, which is Hispanic or Latino, because this contradicts literature saying that they're white, older Americans are more prone to having suicide attempts and completions, and this was different in our population. So some limitations of my study is that self-reported data and a psychosocial assessment. There was only 1 chart reviewer, myself. There was a lack of psychosocial variables and reporting mechanisms to gather data in the general population. So upon doing further analysis, I originally wanted to do a logistic regression and compare the risk factors in the general population of the Institute for Family Health and the high-risk patient population. But reporting limitations, I wasn't able to get data from the general population in a timely manner, and it took a lot of data manipulation to export it into statistical software. And also, I just looked at the psychosocial assessments, whether patients made a past attempt or completion. There could have been other indicators in the chart where they were expressing to the clinician that they were having ideations, or they had a plan, but they didn't do it. So I was just looking at 1 variable and not at each individual clinical visit. So some of the conclusions is that it was a small but substantial number of high-risk patients not in the suicide alert system. So the Institute for Family Health has never had any type of suicide identification research project done. And also it honed in on the Latino Institute for Family Health patients, and they're more likely to be at high risk for suicide. So some steps for looking forward is this is the first EPIC enabled, and that's the electronic medical records, comprehensive suicide ideation effort at the Institute for Family Health. So we're using these results to refine best practices. The Institute now is implementing a mechanism in their electronic medical record where everything is centralized. So the safety plan is in one place, the assessment is in one place, and everything is centralized. And also the clinical implications, in clinical staff meetings where I attended, it raised the importance of focusing on their adolescent patients, their Latino patients, the co-occurring risk factors that are seen and more prevalent in the Institute for Family Health population. And also there's the need for clinical retraining, so training clinicians to put these protocols within the chart so further assessment and alerts can be adhered to. Thank you. And I just wanted to say thank you to Professor Crum and the director at my Institute for Family Health, Dr. Verna Little, and the people that have helped me in my data analysis. Thank you.
Any questions for Erin? Yes.
Hi. I had a couple of questions. One is, I was curious, you said that when a patient comes in and they express, it sounded like past suicide attempts or ideation, how do you train? Is it just your clinicians that are trained to recognize that, or is that anybody, the social workers, the administrative assistants, anybody that they come in contact with?
Right. So all patients, whether they seek medical or mental health services, are given a patient questionnaire, and this is a depression screening tool. So if the patient says that they're not depressed, that's up to clinical judgment if they want to pursue that issue. If they say that they are depressed and they're just seeking medical treatment, they're referred to an on-site mental health clinician. And that's when the psychosocial assessment is given. So only social work interns as well as licensed social workers administer the psychosocial assessment. However, the whole Institute for Family Health staff, we attend SAFE talk trainings, the suicide prevention trainings, how to talk to patients, and we all are required to ask patients, if they're feeling suicidal, and do they need some type of support services.
And were you looking at, like, suicidal ideation, or were you looking at past attempts?
So that was one of the limitations. I was only looking at past attempts. So the suicide ideation, it could have been expressed, embedded within the chart. So there was, hundreds of clinical visits that they've had, and they could have expressed one day that they were feeling suicidal or having ideations, and the other day that they weren't feeling that. So I didn't look that deep within the charts. Yes.
Why is it difficult to validate this comparison in terms of the percentage of Latinos that had suicidal attempts versus the general population?
You said why was it difficult to validate?
Why would it be difficult? I mean, this comparison is problematic to me. Why do you think it is?
In terms of the high-risk patients as opposed to general
In
population?
terms of the comparability of the...
Well, I think for number one, the patients that we serve as a whole are low risk, high risk, underserved minority patients. We are a community health clinic. We provide care regardless of ability to pay. So in terms of comparing that to, or generalizing it's a little bit different. But within a community health center network, it provides us with opportunities to tailor interventions and focus specifically on our patients on a greater level.
Having them side by side may be deceptive to the audience because this population, there is an overrepresentation of minority groups within the population, sir?
Are you speaking about this?
Yes.
Yes, so the first column is the high-risk patient, 83, and then the second is the general population of the Institute for Family Health.
I see. Now that I
Sorry for not making that clear.
So we'll take one more question.
Yes.
A very nice presentation. Do you know how many of the high-risk people completed suicide during the time you were?
14. 14 completed 69 attempts. So we didn't want to separate them just because I didn't have enough completion.
Was there a difference in compliance for those who completed and those who didn't complete?
Yes. Off the top of my head, I can't tell you, but I know 2 patients that completed suicide were not seeking mental health services.
that they were referred to mental health services, do they have the ability to refuse those?
Absolutely. So we were co-located, we have primary care services and mental health services under one house. So the operations, if they're expressing suicidality, they're immediately referred to this, and there's specific protocol in terms of calling 911 if they're at imminent risk or if it's just passive.
Thank you. Our next presenter is Joanna DiCostanzo, who is in the Health Policy and Management Program at Hunter. And the title of her talk is Factors Related to Social Network Formation Among Individuals with Severe Mental Illness.
Good afternoon, everyone. My name is Joanna DiCostanzo, and I'm a student in the CUNY School of Public Health at Hunter College, and I'm in the Health Policy and Management track. My capstone project entailed identifying factors related to social network formation among individuals with severe mental illness. This project was led by Professor Jonathan Prince of the Silverman School of Social Work. So the project was a qualitative study using focus groups to generate feedback on barriers and facilitators to fostering and sustaining close friendships. We then organized these two groups according to the socio-ecological spectrum, so individual level, relationship, community, and society. Examples could include personal behaviors, interpersonal processes, and environmental and social factors. And we were looking at things that were identified as factors that promoted or precluded the development of close friendships for people with SMI. So in order to ascertain why this is an important public health topic, it's important to get a sense of how SMI, which is severe mental illness, impacts the country's healthcare system. So an estimated 26.2% of Americans ages 18 and older suffer from a diagnosable mental disorder, and 6% have severe mental illness. So SMI is an umbrella term that encompasses major depressive disorder, bipolar disorder, and schizophrenia. It also accounts for roughly 6.2% of the nation's healthcare expenditures. However, these estimates do not always capture the full financial scope of SMI. Indirect costs such as downward social mobility, unemployment, public assistance payments, residential instability, and reduced educational attainment are often overlooked, and this can understate the full impact of SMI on the economy. So not being part of the workforce is just one of the many ways in which people with SMI are segregated from the mainstream. Social isolation is a common trait of SMI and leads to erosion of social support and community inclusion. Prolific research has shown that diminished social ties are associated with increased morbidity and mortality and can adversely impact the recovery experience. In general, those with SMI tend to experience increased social network attrition and turnover, and their networks are less supportive and more restricted, with the average network size being half of that found in the general population. So social support is crucial for mental health and well-being and has been shown to promote positive outcomes in areas such as housing stability, emotional stability, and recovery. Social networks have also been linked to a reduced need for professional psychiatric services, while still helping people access those services if needed. And despite the importance of stable social networks, not much is known about why those with SMI have difficulty fostering these close relationships. So in other words, the precise pathways and factors that mediate this trend have not been thoroughly investigated. So our study wanted to address that gap by trying to understand the factors responsible for this trend. Our data collection took place at Fountain House, which is a premier psychosocial club in New York City. The club's working community model is founded on the principles of empowerment and voluntary participation, so members play an active role in their recovery. Fountain House provided us with access to our population of interest, and because the institution is so reputable and well-known, we didn't encounter any problems finding people to recruit. And as you can see, the majority of the members have schizophrenia, which I said before is a severe mental illness, have or comorbid for substance abuse issues, and 40% have been homeless, which demonstrates the variety of psychosocial issues that affect those with severe mental illness. So the focus of my capstone was phase 1, which is highlighted in purple. We conducted 3 one-hour loosely structured focus groups in English with 30 participants at Fountain House. And again, our aim was to extract emergent themes from the focus groups to understand what factors were helping or hampering individuals' ability to form and maintain close relationships. This data will eventually be used to develop a questionnaire in phase 2, which hasn't started yet. But eventually this questionnaire will complement other social rating scales and can be used to assess the extent of engagement in activities and behaviors that cultivate relationship formation. And then phase 3 will test the validity and consistency of the questionnaire. And hopefully the questionnaire will ideally be used to guide treatment plans, clubhouse programming, advocacy efforts, policy, and funding streams. And this is especially important given the burden of SMI on the nation's healthcare system. Okay, so we used a purposive non-random sample, and the first 30 members at Fountain House to sign up were enrolled on a first-come, first-served basis. And each of these participants met our inclusion and exclusion criteria, so we were able to enroll everyone who signed up. The focus groups were kept to 12 or fewer participants to ensure that people felt comfortable talking about personal issues. And we also wanted to give people a chance to really represent their ideas. So smaller focus groups are more manageable. Although the groups weren't structured, we did have some guide questions that we used as probes if needed and when necessary. We decided to keep moderator interference to a minimum because we wanted to elicit candid responses that weren't primed by our questions. So the inclusion and exclusion criteria was just age 18 and over, members at Fountain House, capacity to consent, and Axis 1 DSM-4 diagnosis for severe mental illness. For data analysis, we had 3 coders transcribe each of the focus groups verbatim, and then the transcripts were reviewed by the 3 coders, and we used grounded theory and 3 approaches to qualitative analysis to create a coding framework consisting of categories, which were the barriers and facilitators, then subcategories, which would be the level of the socio-ecological model, and codes, which were the themes. Then we got together as a group to create one mutually agreed upon system. And the moderator, who wasn't involved in the coding process, was involved in the group effort, and he used his a priori discussion guide to determine if the textually driven coding scheme made sense and reflected current theory. So these were my results, and as you can see, each concentric circle represents one level of the socio-ecological model. So barriers are listed in purple at the top, And then the facilitators are listed in dark violet at the bottom. So as you can see, symptoms of illness and freedom of choice are listed in the individual. For relationship level, rejection and connectedness were two major themes. At the community level, stigma and activities. So like clubs and organizations would promote bonding. And with stigma, fear of public discrimination deterred people from forming friendships. And alienation from the mainstream and reintegration and recovery were key societal factors. So this table just illustrates some quotes taken from some of the transcripts, and they're identified by their theme and socio-ecological level. So for example, in relationships, under rejection, someone said, some people, when they hear you have a mental illness, they don't want to associate with you anymore. Whereas for connectedness, one person said, I'm friends with blank because she has a mental illness like me and she gets me. So it's important to understand what factors allow for social network formation, because this will ultimately aid practitioners in assisting their clients. And because there are so many benefits to social networks, it's really important to invest resources in developing those networks. And often macro level factors such as unemployment and residential instability are overlooked, but the variables play such an important part in social network formation. And even on an individual and interpersonal level, public awareness and education to reduce stigma must be supported. Finally, helping individuals with SMI refine communication skills and relationship building skills is really important for personal growth and relationship development. So really quickly, some of the limitations were that this was a convenient sample, so there was inevitably selection bias. People who were interested in the topic, attended Fountain House frequently, and were connected to others were more likely to volunteer. Whereas those who are most at risk, the voices that we need the most, such as individuals who feel isolated or are withdrawn or not as socially well adjusted, may not have been represented in this sample. And we also didn't collect demographic information at this stage, even though it would have been useful in determining whether or not these results could be generalizable and representative of the population at Fountain House. And finally, because those with SMI tend to have severe thought disorders and communication and cognitive deficits, it may have been wise to have a more structured focus group to minimize irrelevant and tangential responses. And last, I'd like to thank Dr. Prince, who was in charge of this study, and Jacqueline Ansbro and Ann Benedict, two social work candidate students who were also involved in the project. And finally, Professor Linda McDowell Greenspan, my capstone faculty advisor. I'm really thankful for all the work that she did in helping me get this project together, and I'm really appreciative.
We'll take just a couple questions for Joanna.
This is really an impressive project. Let me ask you, how do you approach this as a master's student in social work versus a master's student in public health? How would you approach it differently?
If I was in social work?
Yes.
I think the focus would be more on interpersonal relationships and also recovery oriented, whereas from a public health perspective, it's more like how does this influence policy, advocacy, and funding. But also I work in mental health, so it's one of my main interests. Yes?
I'm just kind of curious because I know that it's just some of these variables or exposures that you're mentioning, it's like which came first, chicken or the egg? Because I mean, you can be depressed, but then you won't show up to work and you might lose your job, or you could get fired or laid off, and then you can be chronically depressed. And I just want to know your thoughts on that.
Yeah, it's hard to tease that out, and they're definitely interrelated. That's a good question. I think that the important take-home message is that things like supported employment for people who are suffering from severe mental illness and programs like Fountain House kind of, I guess, what's the word I'm looking for? I guess it would decrease the likelihood that they would further withdraw from their social networks.
Thank you.
Can I answer one more question?
Okay, we'll do just one more from Meredith.
Sure. Congratulations.
Oh, thank you.
I just wanted to ask quickly, it seems that participants with different types of serious mental illness were all included in the focus groups, and I was just wondering if you got a sense, if you sort of qualitatively stratified to understand if the participants with, like bipolar, my anecdotal experience is that they have sort of larger social networks since they're more on the hypomanic side. If that was different than, the people with serious depression.
Well, we didn't get clinical data, but just from being in the focus groups, I could tell that the experience varied depending on diagnosis. So people with bipolar tended to report more volatile relationships and purposive withdrawal of their family members away from them. Whereas people who had, let's say, depression were withdrawing on their own. So that's why symptoms of illness was one of the individual themes that was like a barrier.
Thank you.
Our final speaker for this panel is Kriti Thapa, who is in the Epi Biostat program at Hunter. And the title of her talk is The Impact of Caregiver Depression on Delinquency Among Child Welfare Involved Adolescents.
Good evening, everyone. My name is Kriti Thapa, and I'm presenting my master's essay on caregiver depression and adolescent delinquency in the child welfare population. To provide some background, youth in the child welfare system are at higher risk of adolescent delinquency compared to youth in the general population. Research has shown that youth in the child welfare population have 2 to 3 times more increased likelihood of committing delinquent acts compared to those in the general population. Also, in the general population, one of the factors that has consistently been shown as a significant risk factor of adolescent delinquency is the parent's mental health status, particularly depression and suicidality. Caregivers of children in the child welfare system have higher rates of depression than those in the general population. So the child welfare population is pretty vulnerable. However, no studies have examined whether the association between caregiver depression and delinquency exists among child welfare involved youth. So I was interested in doing exactly that. That is, to investigate the association between caregiver depression and delinquency among child welfare involved youth. Really to see if the same association that we see in the general population applies to child welfare involved youth. Because right now, child welfare agencies across the U.S. are trying to find more effective programs to address negative childhood outcomes in the child welfare population. I also wanted to see whether gender differences existed in this association. And that was for a couple of reasons. First, in the general population, male youth have been shown to be more strongly affected by parental mental illness in this association between caregiver depression and delinquency. And also, recently, arrests among young females have increased by 35%, but decreased by 11% among young males. The studies that have been done in the general population have not only been mainly cross-sectional in design, but have also been primarily male-focused. For my analysis, I used the National Survey of Child and Adolescent Wellbeing, 2. And this is a longitudinal data set which comprises of information on a nationally representative sample of 5,872 youth aged 0 to 18 years who have undergone a formal Child Protective Services investigation stemming from a child abuse or neglect report. Wave 1 was conducted between 2008 and 2009. Wave 2 was conducted 18 months later. And since my outcome of delinquency was only collected among youth who were 11 to 16 years of age, I restricted my sample to this specific age group. My exposure, caregiver depression, was based on the caseworker's report of caregivers' mental health, and it was a dichotomous exposure. And that was collected in Wave 1. The outcome of adolescent delinquency was based on the instrument Self-Report of Delinquency, where adolescents reported the number of times they had engaged in 36 illegal activities in the past 6 months. And I calculated the total number of times each of these adolescents have been involved in all of the illegal activities in the past 6 months to give me a total delinquency score. And I dichotomized this outcome as presence versus absence, with the presence being the top quartile of the total delinquency score, and the absence being the bottom 3 quartiles of the total delinquency score. And this was collected in Wave 2, 18 months after Wave 1. For control variables, I controlled for demographic information of the child, child welfare information, so the living arrangement of the child and the type of reported child maltreatment, as well as family-related risk factors, which were all caseworkers' assessment and report of stress in the family and social support in the child's family. For my analyses, I did bivariate analyses that involved cross-tabulation and chi-square test statistics. And I also did logistic regressions to see whether caregiver depression predicted childhood delinquency. And to investigate whether gender differences exist, and I included the interaction term of caregiver depression and child's gender. I adjusted for complex sampling, which was how the national MSCA was conducted. And from all my analysis, I had a two-tailed alpha value of 0.0.5 cutoff value. And for all my analyses, I used SAS 900. These are my descriptive statistics presented in our chart format. And this slide presents the demographic information. And females were more likely to report delinquency than males in the child welfare population. Though this may seem striking at first, this is actually what's been found in the child welfare population previously, so that is consistent with past research. Older adolescents were more likely to report delinquent behavior, and no significant differences were found in child's race and child's poverty status that is below or above the federal poverty level at the 0.05 alpha level. And this is some more descriptive statistics with child welfare variables. And in-home care adolescents were found to be more likely to report adolescent delinquency compared to out-of-home adolescents. All of the other variables showed no statistical significant differences, and that included my caregiver depression primary exposure. So there were no differences in the report of adolescent delinquency between the two caregiver depression groups. These are my adjusted logistic regression results, and as can be seen in the green box, contrary to results in the general population, though there is a slight positive association, the association is not significant. So caregiver depression, those adolescents who are exposed to caregiver depression are not more likely to have the outcome of adolescent delinquency than those who were not exposed to caregiver depression. You can also see that the p-value for the interaction term that I included for caregiver depression and child's gender was not significant as well, indicating that contrary to findings in the general population, that the caregiver depression does not act differentially between the genders. To conclude, the study appears to be the first to investigate the association between caregiver depression and delinquency in the child welfare population. From my bivariate analyses, I could conclude that female adolescents in home care, and those who are older are more likely to report delinquent behavior. And contrary to studies in the general population, there's no significant association between caregiver depression at baseline and adolescent delinquency at the 18-month follow-up after adjusting for confounders. In addition, there's no significant gender differences in this association. Some limitations to consider was that I had dichotomous variables. Although I may have lost some information by dichotomizing my variables, it allowed me to compare my findings with findings in the general population and past research. Also, my outcome of delinquency was self-reported, which may have introduced some form of recall bias and misclassification. However, the self-report of delinquency instrument that was used has been shown to have relatively high validity and precision. And because it was a longitudinal study, there may have been selection bias due to differential loss or follow-up from the adolescents who continued from wave 1 to wave 2 versus those who did not. However, I did conduct a comparison of the characteristics of adolescents who were lost to follow-up and those who were retained in wave 2, and I found no significant differences in the characteristics between those two populations. Implications, it's important to realize that child welfare population is unique, and the interventions that have been recently designed in the general population that incorporate addressing parental mental illness as a means to prevent childhood delinquency may not work in the child welfare involved youth. It is also important to conduct further research to identify factors leading to delinquency so that effective programs can be made specific for the child welfare population. I'd like to thank Professor Marina Lowians, who's the PI for this project, and Professor Jonathan Prince, who helped in some of the statistical analysis, Jennifer Bright, and the capstone faculty for their constant support and guidance, and the rest of the Keene School of Public Health for giving me the capacity and opportunity to do this research. Thank you.
So you dichotomize the score, delinquency score.
Yeah.
Did you try different cutoff point and compare results and then see if you can get a better p-value?
So the reason why I dichotomized it in that way was how past literature that have been done in the child welfare population and in the general population had categorized the delinquency scale, so that I could make my results comparable to those from past studies.
So the way your border on the score is also the follow previous study?
Correct. Correct.
Thank you very much for that presentation. And sort of the finding of higher rate of delinquency among females than males is sort of counterintuitive, at least culturally. Were the types of delinquencies among the females different than the types of delinquencies among males, or is that not in the data set?
So the way I looked at it, delinquency, it was calculated overall, and the delinquent acts that were investigated in this survey was minor theft, felony assault, property damage, public disorder, status offenses, and felony theft. And it was actually across all variables except, I believe, property damage, where females had higher reports of delinquent behavior. And keep in mind that this is their self-report, and it's not ones that actually resulted in arrest.
One more question for Preeti? Or we can move into the... Oh, sorry, Martha has a hand up.
I was wondering because we had Project Sub people here that are to for violence interruption program a month or two ago, and they were very concerned about violence among young women and said it was quite high and felt that it had been sort of ignored. You know? So it's just interesting. I found that very consistent.
Yeah. Particularly now, the emphasis among child welfare research is to focus more on female negative childhood outcomes because, like you said, it's been neglected in past research.
Great. Thank you.
So now we come to a very exciting moment and another first for the CUNY School of Public Health. You have just heard the 4 Faculty Research Award winners. Let's give them another round of applause. Of these 4 winners, one is going to get the Dean's Award. And I turn it over to Dean El Mohandes.
Well, I emphasize that you're all winners. So whoever gets the supplemental check is just going to invite the others to dinner. That's how I see it. Because otherwise you would easily share that check. I'm very, very proud to present the first Dean's Award on Research Day to the students that presented today. And it was really very difficult to select amongst you. I hope that there will be even a more widespread representation from all the campuses of the CUNY School of Public Health. I want to see more from every campus present and win awards. But I must say that I'm very, very impressed by the quality of the presentations today. I had to come up with a grid, as a public health academic should, of how I'm going to score you, and I just invented it. And it just happens that I really was very happy to see that some of you did venture into doing some primary data collection. It is most difficult, it is most challenging, and I applaud those of you that did that, but that is not to say that approaching data that is pre-existent and putting in your energy and your intelligence into it is less worthwhile. I also measured the quality of the presentation itself, the time and effort you put into your PowerPoint, and the confidence when you stood at the podium and you responded to the questions. The differences between you are minuscule, hair thin. I cannot emphasize that enough. But having said that, one of you has to win the first prize. And as such, the Dean's Prize on Students' Research Day this year, I'm very proud to admit, will go to Joanna Di Constanzo. I'm very, very pleased. You will continue to remember yourself as the first ever winner. Congratulations. Good job, young lady.
Okay, and we're ready to move on to the next room with the...
And congratulations to all.
The next panel.
And to you. Job well done.
Congratulations. Daniel Lopez Pino. Congratulations. Sarah Louise. There she is.
You should also say the campus they're from.
Which one? Oh, I should say what campus they're from?
Yeah.
Hunter.
So you, and where are you from?
Daniel, Brooklyn College.
Hunter. Hunter. There you go.
Thank you.
If you know, I'm
Congratulations.
putting her on the spot.
I mean, I can also read the titles of the posters, but I think that's going to
No
happen.
worries.
We'll
No
have
worries.
faculty, so we will get to that. And Dana Milano. Lehman. Josephine Mays. Wonderful. And you're where?
Hunter.
Okay, and we have, as Linda said, one food policy poster winner that Ashley's going to present. So please, go right ahead. Here, right here.
Hello, so my name is Ashley. I'm here to present the New York City Food Policy Center Food Policy Research Symposium Poster Award. Just our quick little spiel. The New York City Food Policy Center develops intersectoral, innovative, and evidence-based solutions to preventing diet-related diseases and promoting food security in New York and other cities. We work with policymakers, community organizations, advocates, and the public to create healthier, more sustainable food environments and to use food to promote community and economic development. Through interdisciplinary research, analysis, evaluation, and education, we leverage the expertise and passion of the students, faculty, and staff of Hunter College in CUNY. So that being said, the poster that has been selected to receive this award is Voices Through Cameras, using photo voice to explore food justice issues in New York City youth. The two award recipients, Lorraine Harry and Julia Sharkey Buckley, have demonstrated an innovative and carefully coordinated approach to researching and presenting their findings on these pressing food issues that face our city. So we thank you for your contribution, and we urge others to pick up the mantle and work on this really important topic. So thanks.
Thank you. Sorry.
Sorry.
Thank you. And now to put the poster research in context, we have this distinguished panel of our faculty. And I think we'll, thank you. And should we just go in order? Is there, okay. So first, well, yes. And why don't you, I will let you all introduce yourselves. And first, Professor Calvin.
So I'm Elizabeth Kelvin, and I don't usually use a microphone because I have a pretty loud voice. I grew up with a hard of hearing father, but I guess I'll use it for now. If you can't hear me, let me know. So I'm going to talk about the poster by Daniel Lopez Pino. And his poster was titled Assessment of Performance Measures in a School-Based Mental Health Crisis Intervention Program for Children and Adolescents. And his project was to evaluate the performance measures used by the New York City Department of Health to evaluate the Mobile Response Team program. The New York City Department of Health Mobile Response Team program served 10 middle schools in Brooklyn and provided mental health services to the students in those schools. The program included having mental health professionals on site at the schools at least once a week, and also being available for crisis outreach whenever it was needed in those schools. So Mr. Lopez Pino applied the National Quality Forum Evaluation Criteria Framework, and that's a mouthful, to the evaluation methods that were being used to evaluate the success of the Mobile Response Team program, and found that the evaluation methods used included criteria that looked at process and outcome measures, but there were absolutely no criteria looking at structural factors. So they kind of missed a whole area of evaluation for the program. Furthermore, there were a number of evaluation criteria used by the Department of Health that did not fulfill any of the three most important criteria included in the framework. So some of the criteria for evaluating the program didn't really seem to fit within the framework very well. So, you know, in healthcare, there's a big push right now for program evaluation, and we really want to spend our limited resources on evidence-based programs that we know work. I think Mr. Lopez Pino's project highlights the fact that the evaluation of public health programs is only as good as the evaluation criteria that's used to evaluate those programs. So really a lot more thought needs to be put into formulating evaluation criteria and applying a framework of evaluation and design of program evaluation criteria. And this process should become much more standard rather than just throwing together a bunch of criteria that we think are appropriate for evaluating programs. Well done.
So did she get it right?
Yeah.
Ah, good.
I'm Meredith Nancy. I'm at Hunter College, and I'm going to be talking about two award winners. The first is Iman Tabara, who is at Brooklyn College in the Health Policy and Management program. And she set out to understand what primary care providers can do to ameliorate the problem of childhood overweight and obesity. So recognizing obviously that obesity is a growing epidemic and problem, and that we need interventions at multiple levels to try to intervene for early detection and prevention. The clinical encounter she saw as an opportunity, a unique opportunity for providers to intervene and counsel and potentially have an impact on that. So she reviewed the existing literature about what interventions have been conducted that have been successful in this clinical exchange, and found that there were 3 main interventions. You can tell me. This is what I got out of the poster. 3 main strategies to improve how providers can counsel. One is to assess BMI at visits with their fee applications. The other is brief motivational interviewing that could happen, in a very quick but impactful exchange between the primary care provider, the pediatrician, and the patient and the patient's family. And also referrals to nutritionists or other specialists outside of their expertise. And she reviewed the literature and found some good sample sort of guides that providers could look up and review to understand more about how this works in the clinical encounter, such as the Maine Youth Overweight Collaborative, and also using strategies such as the 5 A's approach, which is for providers to assess, advise, agree, assist, and arrange with patients. And this is an approach that has been used in the healthcare setting for other issues, including hypertension and smoking cessation, has been proven to be successful. So I think this is a good start to understanding how we can maximize the time in our brief clinical encounter that we have, and to move forward to understand more about how we can impact childhood obesity outcomes in this setting. Do you want to add anything? Good. Okay.
You got it right.
Okay, great. Yeah, congratulations. So the next student is Dana Milano, who's from Lehman College in the MPH Community-Based Public Health and Health Equity Program. And she set out to understand if traffic volume as a neighborhood stressor in the South Bronx, how that might affect infant mortality. So infant mortality also, as we know, is a major problem in the United States. It has become a marker not just of that, but also of societal health in general. And indeed, the high rate of infant mortality in the U.S. Is an example of reflecting issues that we have in other aspects of health in our society. So in the last few decades, we've increased our understanding a little bit and progressively of what contributes to infant mortality, and expanding our conceptualization of infant mortality to include issues across the life course, not just in the prenatal period, including things like stress, racism, and things like that experienced over one's life course up until becoming pregnant. And so Dana, with another intern, conducted an audit of different neighborhoods in the South Bronx last year from April to June on weeknights, assessing things including traffic volume, and assessed if there were sort of, they categorized it as light, moderate, and heavy traffic volume in the neighborhood. And she found that the large majority of sections in the South Bronx had traffic, more often light volume than moderate or high, but still traffic that was pervasive in the area. And so this, to me, seems like a project that is the start of how we want to move forward in thinking about traffic volume or other issues in traffic as a factor that impacts infant mortality, and broadening our understanding of that as we move forward in the field. So congratulations, Steve. Thank you.
Okay, now we're going to
to move on to environmental occupational health sciences. We have 2 students who also won awards for their posters with slightly different topic areas. And for those of you who don't know me, I think there are just a few, my name is Grace Sambajwe and I'm a faculty member in environmental occupational health science. So I'll start with the first one, which was entitled A Brief Look into the Effect of Noise on the Quality of Life in Communities Near Airports. This topic area is actually quite interesting, especially for me. I teach the physical hazards class and look primarily at exposures to noise as they relate to hearing loss. I mean, we often think about noise and hearing loss going hand in hand. But what Josephine did was to review literature that looked at individuals who are living near airports and how they were affected by the noise in ways that were beyond just noise, hearing loss. She decided to review literature that looked at other types of health effects, including high blood pressure, stress-related hormone effects, I think you noticed in the literature. And what I didn't notice, though, in your review was some of the new information coming out about acute hyperacusis, which is a dizziness imbalance and the general malaise associated with people living close to airports. And I think you probably had one article which wasn't very useful to you and you threw that out. So with Josephine's work, she reviewed about 60 articles on noise and hearing loss, restricted it to communities near airports and particularly near JFK here in New York City. And what she did find from those articles is that the majority of them, about 40 out of 60, actually identified health effects that were unrelated to specific hearing loss effects. And to her, this was a finding that she felt should be addressed in future research in environmental and occupational health studies that are focusing on some of the sub-level noise that we tend to hear around communities that are exposed to either to airport noise and sometimes factory noise. And right now, I think the bus depot here in Harlem is another area where there's going to be a number of complaints and health effects associated with the truck and bus noise. Josephine, congratulations. Is there anything else you'd like to add to that? No? Congratulations. And the second student poster prize was awarded to Sarah Lewis. Congratulations. And the poster was entitled Radioactivity Emission in Flowback Water Due to Hydraulic Fracturing. And for those of us who listen to the news and maybe perhaps don't necessarily focus on environmental and occupational health topics, hydraulic fracturing is the fracking controversy. The methodology used to extract gas and other types of oil and natural, I think, materials from shale, right? And what Sarah was focusing on was the radioactive materials that tend to get mixed in with the water that's used at high pressure to extract or to create cracks in the shale that then allows the methane gas, which is primarily what you were focusing on, and other natural gases to then be available for the process. Am I correct? Yes. And similar to Josephine, Sarah did a literature review of mostly EPA public reports and public feedback to see whether the public actually felt the same way or was aware of the hazard associated, and this is a radioactive hazard associated with this kind of extraction. And I don't know in your poster, but in your paper perhaps, you identified some of the radionucleotides, the radioactive material that is actually naturally occurring, but is then enhanced and concentrated in the extraction process, which can cause a concern. I didn't see that in the poster so much. Yes, I did think right. And from the literature review, Sarah found that a majority of people in the public were aware of the radionucleotides, but there was still quite a number of response from industry that seems to be more favorable and play down the hazard of radioactive material and the release of radioactive material because of this type of extraction of gas. So with that, once again, congratulations and thank you for sharing this.
Are there any comments or questions of either our faculty who are in these research areas or our students who have presented these fine projects? Because if not, it's time for refreshments.
Before we leave, please allow me to direct your attention to Professor Linda McDowell, who's played a fantastic role in making this happen today. She is the soldier behind the scenes that is a great advocate for students and student research. And also to thank Professor Mimi Faz for her participation in making this happen today. This was a very successful day, and I think a new chapter in student research activities at City University. I, as your dean, am very proud of your achievement and very proud of my faculty who are really your best advocates. Thank you all very much.
I want to echo our dean's thanks to Linda McDowell, who's been amazing, and also thank our dean for his spirited involvement. And thank you all so much.
Even if you're qualified.
I noticed that.
Anyway,
Not
this
like
is
could
have been amazing. Well, no, it's a lot.
But no.
This is Martha from my husband Bob, my daughter Kat, my son-in-law on Saturday. Yes, very nice to meet you. We're going to miss you. I know. Oh, really? I'm proud to have over the years. Oh, yeah. But I just feel who's going to do it next year? Yeah, my son was here. Just like sing. I didn't mean no, I didn't do it. I appreciate it. I appreciate it. All right. Did you have another?
Well, they gave me their associate, so it was it was an accident on their long story, but once that was over, I'm out of story.
She kept one of those wheels, but I think it's a really exciting time in the school.
Yeah,
it is. So I think it's more.
You have the lids for these?
Yes, underneath.
Oh, good enough. I'm sitting with you too. I was like, oh, good.
I'll be outside.
Are you collecting the water?
Programs, yeah, I think so. Next year we should just try to make all these digital if we can, you know, do like a join me, make the digital. Such a waste of time.
Okay, yeah, so that I'm gonna put up on the 5th floor by my office, I
Okay.
think. Yeah, all right. In fact, I'll take that. And then the only other thing I need to do is I need to get these 2 easels. Yeah. One goes to,